Well, good morning, and thank you for that very kind introduction. As you see, we're really wired here this morning with two speakers, one for the in-house and one we're recording, because this whole seminar series will be on podcasts available via our website and also housed in our digital library here at UTEP, so it can be accessed for any of you in the future for your research or information needs. This morning, I'm just going to take a little bit of time to share with you a general overview of some of the health and health disparity related issues along the U.S.-Mexico border. And the speakers that follow me later today will be speaking more specifically about some of their work that they're doing in regards to some of these issues. So mine's more of a general overview, so we'll see if this all works. And I'm going to stand out. I guess I can't stand out too far. Hispanics, as most of you in this room I'm sure know, are the fastest growing minority group in the United States, and by 2050 estimated to be 25% of the population. They're currently around 14% according to the latest census data, exceeding African Americans, which are somewhere around 10%. So it's a very large and emerging group. Even though immigrants have been our primary source of growth, and then with them settling here, as those of us living here on the border understand the current issues in Mexico with some of the violence and the border security with the big fence that's been put up by our former president, has in some way slowed down some of the immigration as well as the economic slowdown. But the extent of how that may play out in the future is still kind of unknown. You can see the probability of Mexicans who immigrated from Mexico or even in Central and Latin America, South America. Many folks came over for employment and then went back home after they had generated enough income, and then tried to come back across the border. But with now the additional security related issues, that's becoming more problematic. In fact, I was just reading that the amount of money that's going back to Mexico from individuals in the U.S. is dramatically dropped. So that is creating an additional economic crisis in Mexico, because families have been relying on those kinds of income for their well-being. So the restrictions until recently have not had much impact, but we certainly, as I said, seen a slowdown, at least along this portion of the border. I think maybe in some areas, other areas, it hasn't been as significant, but it certainly has slowed down. And of course, with people hesitant to go back, it does create issues around families. Often, as you probably know, their family, mother, father, children, wife, may live in Mexico and not able to go back because they're concerned they cannot get across the border again. Creates a lot of issues around families and that issue. You've probably seen also some of the other immigration concerns as mothers that have children that are born in the U.S. and then they're going to be deported. Then that issue that comes around the separation of the families and how that all plays out. So that I'm sure many of you could tell personal stories of individuals that you've experienced and know that has been a real kind of dynamic that has occurred. In terms of leading causes of death, as with the general U.S. population, heart disease and cancer is still up there. Diabetes is growing, and you'll hear later this morning from Dr. McCormick more about diabetes and how this is really kind of mushrooming. Of course, here in the border, homicide, particularly in our neighbors across the way, is a major problem. We hope that it doesn't spill into the U.S. side, but that's always a major concern. Children, preschool children in the U.S., 1 in 4 are Hispanic children. And with that is the cultural and linguistic issues that surround that. In some school districts, for example, California, you may have seen that there are significant budget problems, and they're blaming a great deal of that on the large immigrant population that they have to teach in the language of the children from many different countries. And so there's always somebody that they want to blame, and often it's these poor kids that are the ones that kind of get stuck in that. And of course, as we'll talk about how these things can lead to health inequities. Hispanic children are our largest minority group of children in the U.S., as are the adults. And children now are up to 16% of the population that are under 18. So just that large percentage is going to start changing the dynamics. Again, those of us on the border, like in our region, we're around 78%. I think Brownsville's closer to 95, something like that. We do not perhaps see it as much, but when you get outside this region, up into Colorado, Kansas, beyond this area, the large influx of immigrants and people that are resettling is causing a lot of interesting issues, should I say, particularly in relationship to delivery of healthcare services and educational services. Unfortunately, around 27% of the children live in poverty. As we know, when we look at social determinants of health, social economic issues are a significant contributor to poor health outcomes. Over 1 million, which is greater than any other racial group, are uninsured Hispanic children. Recently, President Obama, one of his first acts was to increase the funding for the Children in Health Insurance Program, the CHIP program. And we'll wait to see how that works, because often in Texas we have not been very, very good about getting these children that are eligible enrolled into these programs. And partially is because of concern around immigration status, and parents are afraid if they register, there may be something that may eventually come up in a deportation, or other issues around receiving any kind of insurance from a governmental agency, or lack of knowledge. Health literacy is a huge issue, particularly with our monolingual speaking individuals. The information is often is very white, and as I say, in English, and they may not understand fully what they're being talked about, and the opportunities to take advantage of these insurance programs. So it's a very complicated solution. So Hispanic children are most likely to have health problems, and only 21% of the children are not up to date on immunizations. So certainly high risk for type 2 diabetes and obesity. It's almost an epidemic. And as I say, you'll hear more about that, with boys being the most overweight, girls second most overweight racial group, and Mexican children much more overweight than whites. In fact, I read something recently that the epidemic of obesity with youth may cause an early demise of this population group as they reach in their middle age. If the obesity moves into diabetes and other cardiovascular diseases, etc., and they're not properly cared for, it could cause early death, premature death, or significant disability in the prime of life, which is very concerning, because typically diabetes and those types of issues, we don't see that until midlife. But now we're seeing a huge number of this in children. So that's a major concern. More than half of the Hispanic children have asthma. We have a project here in collaboration with the University of New Mexico. One of our nursing professors, Dr. Maria Maya, is a co-PI in that grant, and several nursing faculty are involved in looking at the incidence of asthma and all the issues around that. And it is quite a significant problem here, particularly in this area. Adolescent births, they have one of the highest rates, 50 per 1,000, and compared to African Americans and compared to whites. In 2005, 25% of the population were obese. I've kind of covered that, but this gives you some local data. Here's El Paso Hispanics, non-Hispanics, and then Donna Ana is our county. Those of you who are not from here, right up north of us in New Mexico, our colleagues from New Mexico State University are here from Donna Ana County. It gives you an idea of the spread there. These are the people. This is from the Border Health Survey. This is done by the Breakfast, funded by CDC. These are the numbers that have found. These are based on telephone random calling. Our household survey shows at least twice that rate, and in some areas it's even much higher. So I think you need to look at this data with a lot of skepticism, that I think it's significantly higher than what is being reported. And I know Dr. McCormick will talk more about that in the Brownsville experience. In terms of Healthy People 2010, which is the report that's put out in terms of goals for the nation, as you see, we're almost at 2010. When they did a midterm report, which was in 2005, of the 24 of the 38 core measures, Hispanics were not making progress in comparison to other minority groups. Everyone else, including African Americans, the gap was closing, but for Hispanics, the gap was widening. And now, when we do the follow-up data in the near future, we'll see even more about that. And by the way, Healthy People 2020 is now being developed, and one of our doctoral students, Moya, is been appointed by the, I believe, the President Bush, to serve on that committee, as they're now creating these the core measures for Healthy People 2020. So we'll see how that works. Tuberculosis, is an issue. In fact, we find a high rate of tuberculosis in the border region. We have a number of projects in regards to that, because with people moving back and forth, as you know, the TB doesn't care where it lives. It just it goes to wherever it can find a place that would be nice and warm and cozy to do its thing. And so this is one of the pluses that we have had with Mexico, is a very active treatment follow-up program, so we could track these individuals back and forth across the border. Now, with the recent issues around all the border violence, I think we've seen a lot of this kind of slow down. And this is a big concern, because if our health departments are not working as closely together and our health workers going back and forth, we get concerned what's happening with the tracking and monitoring of these particular patients. Because, as you know, TB is a infectious disease, and it can be quite serious. These, in terms of the breakfast, it looks at fruits and vegetables. They recommend 5 or more per day, and I suppose if I ask us in this room, I don't know how many of us would be in adherence to this or compliance to this. But when we looked at it, you can see the numbers are quite low. And part of that, going back to what I was mentioning earlier about social determinants to health, is many poor communities simply do not have access to fresh produce and fruits. I don't know if you've gone in the South Barrio here, or if you've gone to San Eli. These are some of our local colonias. The mom and pop grocery stores simply do not carry it. They have frozen items, whole milk, pastry, lots of pastries. And so the access to such issues are quite limited. In fact, those of you that are nursing students in community health, we're hoping that will be one of the activities you might take on, is how can we work with communities in a community participatory method to ensure that we have vendors who are willing to come in and provide that kind of fruits and vegetables so that the local communities can take advantage of them. Physical activity, you can see as a country, we're not even, half of us are meeting it, and as you look at the numbers, it's even less. Some of that is because we don't have safe parks, or air pollution, or other issues, motivation. I mean, there's multiple factors associated with that. In fact, our center funded one study that looked at roaming dogs, because here in our desert, sometimes people dump out their dogs, and if you live, like, say, for example, the study was done down in San Eli, you can't go out and walk because you're going to get attacked by the dogs roaming around, and so that prohibits you from doing the exercise. So our project there was a spade, where we would spade dogs, as well as some of them were euthanized that didn't seem to have owners, so that the community was safer and that people could take advantage of some walking. In terms of binge drinking, 5 or more at one occasion is considered binge drinking. So spring break coming up for you students, keep this in mind. We'll have you part of our statistics. But the numbers are relatively high if you look at it. I was surprised in some of our work that we've done in some of the colonias, the numbers actually is a little bit less than this. So I don't quite understand the totality of that meaning, but binge drinking is obviously a concern because that's linked into driving often. Blood pressure, high blood pressure, pretty high number there. Dr. Bacasa, who you heard from earlier, has a very interesting study going on looking at cardio risk factors within a underserved population in our area, and they have some very innovative outreach methods that they're trying to do intervention-wise to see if they can identify people at risk and then hopefully get them under treatment to control their hypertension. Very, very interesting work that they're doing. In terms of people looking at their health status, you can see how many people felt they were fair to poor, which I thought was kind of interesting. If you look at the look, it's almost, what, more than double. Interesting perceptions of how people see themselves in terms of their health. Now this is, those of you from here, I'm sure, know this border, but just wanted to have a visual. I had a practice run giving this talk in Sydney 2 weeks ago, so you're my second guinea pig. So I wanted to make sure that they had a visual so they could see what it looks like. It's very long. It's over 100 kilometers north and south in terms of width. It's 1,951 miles. We're El Paso, we're kind of right in the middle. We're actually closer to San Diego than we are Houston. A lot of people don't realize that, but we are. So in terms of the length of this border, it's huge. And you can see the number of counties and paired sister cities that are involved in that. If you look at the population of Texas, New Mexico, Arizona, California, in 2003, it's over 66 million of the border states. And if in the Mexican border states, it was 18.4 million, with approximately 25 Native American tribes in that border region. So it was significantly. And of course, they have a lot of interdependence with their historical relationships, particularly with Mexico, economic, social, and cultural. So we're very, very much intertwined. If we were a nation, we would have 13.7% of the nation's population. I mean, as the U.S., and at the border region, it'd be 55.3% in the border states, and in the border itself, 8.4%. Three of the 10 poorest counties in the U.S. are located along the border. In fact, here in our region, in north of us in New Mexico, in Sunland Park, and here in San Eli and some of those others, our colonias, if they were considered a developing country, we would see missionaries coming here to provide outreach and services. So often people think to do missionary work, you have to travel abroad. Unfortunately, colleagues, it's right here within 5 miles of this location. We have extreme incidences of poverty. Now this data is old. I'm sorry, we tried to get a current data, but it was tough to get at the moment. But Pima and San Diego County, we consider our outliers because the Californians, at least until recently, are much wealthier than those of us living in Arizona, New Mexico, and Texas. But the unemployment rate at that time was 11.2. It's estimated it's probably doubled at this point with the economic slowdown. And this rate, as you know, right now we're around 7.5. This is kind of startling. A lot of people don't realize this, but over 400,000 people live in 1,200 colonias along this border region. A colonia is an underserved, unincorporated part. Usually they have no water system that's trucked in with a cistern. They may not have running water, obviously, bathrooms or outhouses, that type of thing. And a lot of underserved, they're not incorporated service from the cities. Fortunately, there is some effort to improve this, but it's almost 500,000 people live in these developing, if you will, or in underserved areas. If the border was the 51st state, you can see how we would be. We'd rank last in healthcare providers. I know in Brownsville and El Paso, Brownsville's worse than we are. They have fewer providers per capita than we do, and we're about half of the national average here. So all of you that are health providers, you should find employment. Asthma rates I've already talked about. 1/5 of the deaths are due to diabetes. AIDS, Dr. Ross is going to be talking with you a little bit later as an expert at HIV. Will maybe address this a little bit more, that we still have quite a high incidence in this region. In fact, one of the growing HIV infections is among young Hispanic men, as I understand it, under 30. And Dr. Ross will probably talk a little bit more about that. But it's a growing rate, and even with all this money that's been put into prevention, it doesn't seem to be going in the right direction in a lot of ways. And of course, then access to care. If you're going back and forth across the border, the tracking of these patients is almost impossible at the moment. As I mentioned, we do have something with TB, but with the HIV, it's almost impossible. We see, of course, in the immigrant people, particularly farm workers, farm workers who come across, many of them with work visas, the incidence of HIV is higher, often undocumented, because it's quite common that the sexual behaviors are different in the camps than what they'll find when they go back home. And so the rate of infection is higher. TB, quite high, and of course diabetes, as we already kind of talked about. Teen births, I mentioned this earlier, it's 3% lower than the rest. This is in terms of some good news. Infant mortality is less than in the national rate, and this is what we're kind of thinking about is the Hispanic paradox, meaning there are obviously some protective factors here, so not everything is doom and gloom. There are some very positive things, and one of the things our center is trying to understand is what are some of the strengths that groups bring that we can understand better, that we could then pass on to other kinds of conditions and perhaps make a difference in the outcomes of care. Because a lot of thinking has been related to acculturation, that the longer an individual lives in the U.S., they become more acculturated, more like the majority population, and develop all the various chronic health conditions that go along with that. But we're not seeing that in infant mortality, or are we seeing that in low birth weight children? As you know, we have one of the highest teen birth rates, though, in the nation, is among Mexican American and Mexican youth in the border region. And I see one of my doctoral students nodding her head because she's going to investigate that whole area. Death causes, just as one might see the differences here, in Mexico, diabetes is number 2. This is at 2000, the most recent data I had. Kind of parallels the U.S., but a tad bit difference. Accidents, as one might expect because of access to care in rural areas. This is a visual. The red is the Hispanic in terms of death rates at the U.S. border. You can see, the total and how the outliers are there. Now, this is the one that really stands out, is the diabetes. Look at that. It's just, and cirrhosis, auto accidents, nephritis, which we expect from the kidney disease from the diabetes, etc. Homicides. Insurance, as you know, is a problem on the border. In this region, in El Paso County, 40% of the individuals do not have health insurance. And then some of our work with the Colonia is up to 60% have no health insurance. As a nation, we're somewhere around a little under 15%. Now, hopefully, with President Obama's plan, which he just introduced some concepts about that yesterday, I don't know if you saw that, we will have some type of health policy that will cover more Americans and more people living in our country. But it's yet to be seen if the Congress will move forward with that or not. As you might expect, mortality is much higher for those who do not have insurance, simply because they may not get in for the acute care for their chronic conditions. They may just simply live through the acute episode, and as the chronic condition continues, it deteriorates over time. I talked about the insurance area. You can see the differences here between Hispanics and non-Hispanics. Look at this. Primarily due to economics. Again, going back to social determinants, economics, employment status, income, and maybe some health literacy related issues. Those of us on the border until recently may have gone over to Mexico to buy some of your medications and bring them back. Some of you still may do that because the cost is so much less. This is just an example here of some of the prices. And of course, dental care, many people, even some of our faculty, have gone to Mexico because the dental care is quite excellent. But with the recent border violence issue, this has changed substantially. In fact, in Juarez, there are 2 state-of-the-art hospitals that were built prior to the border violence issue to provide health tourism. State-of-the-art medical care to bring in U.S. people for like gastric bypasses and other kinds of plastic surgery, if you will, cosmetic surgery. And they're about 1/3 of the price, and they're all investor-owned, and so the quality is quite high because if you run into any untoward problems, then the business goes down the tubes. And I went over and saw them, and I was very, very impressed. In fact, they wanted our students to come over for clinical experiences, but because of the challenge at the moment, we probably won't be able to do that, but I was quite impressed with what they have. Obviously, people go for a variety of reasons, the cost, ease, etc. In the U.S., we have a very restrictive formularies that drugstores can sell to you, whereas in Mexico and other developing countries, you can buy many things over the counter, and that's evolved through time because of the lack of access to care. In terms of policy issues, we have significant demand for health providers, health professionals, all along this border region, particularly in New Mexico and Texas. And it's very, very difficult to recruit them and keep them. In fact, I was just understanding recently we have a brand new hospital on the east side of town, and they're having trouble just getting physicians to go to the east side of El Paso because they think it's too far out. So can you imagine then wanting to go to Fabens and Fort Stockton and all those other areas, or even further out into the Panhandle? So, and I know Brownsville is even worse. Their challenges are even greater in relationship to the number of providers to recruit and to get them to stay. The National Health Service Corps, which President Obama has allocated, I believe, $150 million. I may have that number wrong, but to markedly increase the number of positions that they can fund for new graduates to go out and work in these areas as a way to pay off their loans. And in return, they provide a service to their communities. So some of you with high loans from your schooling, you might want to consider that. You get a good salary, and loans are forgiven over a payback period of time. Here in our area, in Doña Ana County and El Paso, Arizona, lots of retirees coming in, and of course, with that, bringing with them their chronic diseases and the issues that they need to have health services for. Another challenge for our community is the large influx of soldiers from Fort Bliss. With the dependents, some of the numbers I've seen recently, it's going to have up to 50,000 new residents coming in, all needing health care and health care services. So that puts a demand on us. As I talked about the difficulty in tracking infectious diseases, this funding has decreased over time. Hopefully I did see that in the stimulus package, more money for public health. So hopefully that will get down to the public health departments at the county and state levels so they can begin going back and tracking these things and the way that we used to manage the number of infectious diseases. One of the issues we also see, particularly with Mexican immigrants, they may not understand how the U.S. healthcare system works. So if you go to a hospital emergency room, of course they're going to charge you a huge amount of money just to go into that emergency room. And if you don't have a lot of money in the first place, and then you got to get this big bill, and then if they have a phone number, the collectors will be calling and trying to harass you to make a payment. That's going to defer you big time because most people don't want to owe money, and let alone have a bill collector coming after them. And in some of our work in looking at did people not go back for health care because of bills from providers, we found about 15 to 20% did not go back for follow-up care because they couldn't pay for it. As you know, our county hospital, Thomaston, is charged with at least providing the care for those who cannot pay. But I can assure you, they do have a very aggressive collection program. Anyone from Thomaston here? There you go. Because Jim Valenti will tell you that you try to collect as many as you can, and so that may be a deterrent in some ways. Uncompensated care, again, that's the most current data I could get, but the number is substantially over 100 million now, we estimate. Just here in our particular region, Thomaston Hospital, which is our public facility, has had to take care of a number of the shooting victims from Mexico who were U.S. citizens that came over. And so the uncompensated care for that has been significantly high for the county hospital to pick up. So uncompensated cases, care, as you may or may not know, is passed on in property taxes. So as a homeowner, I am taxed, as are those of you, a percentage of the value of your home that goes to the county hospital district. So as that uncompensated care increases, that number increases. I would like to say, though, that in the past 2 years, Thomaston has had a surplus of $70 million. So it's not all gloom and doom here. Part of that excess revenue has been a way of going back and capturing some of the Medicaid payments that they were not entitled to under the previous kind of regulations. And so Jim and his crew have been very good about going back and capturing as much money as they can. So I think this year there's somewhere around a $19 million revenue surplus. But as you can imagine, with the uninsured, the growth that they need to maintain, because they're building a children's hospital, all the other things that we need to have services, that's a very small revenue base to work with. The state of Texas has worked on a Code Red report. I think, Joe, you were on that committee, weren't you? I forget. But there was a number, oh, Hector was on it. Yeah, Hector was on it. There was a number of people across the state working on ideas and suggestions on how to deal with this health crisis within the state of Texas. That's why they kind of call it a Code Red. I think, unfortunately, I don't think much has really come out of it other than it's been a kind of a focus of discussion. Now, maybe we're going to have now health insurance. My guess is it won't be something like we see in Canada and other places. We may have some modified form. Just depends on the political climate and what happens with the deficit. So I think we're optimistic that something might happen. There are innovative programs of insurance in Mexico. In fact, California has a program with the California Blue Shield Blue Cross where people can go get care over there, and the monthly premium is only $18. We have something similar here under El Paso Works, I believe it's called, where you can go into Juarez. You can buy insurance and go into Juarez for your care. Given the border challenges at the moment, it's probably not going to be a viable long-term option. Hopefully the border violence is a short-term issue. We'll probably see mandatory small business insurance pools. Many states and regions have worked around that. For example, the city of San Francisco has a kind of a mandatory insurance plan, and they have clinics throughout the city. So if you don't have insurance, and the employers have to pay a fee to participate, and they're trying to provide primary care. In Massachusetts, they have some other innovative models. So in the lack of a national plan, what we've seen is a lot of city, county, and state efforts, primarily city, county efforts, to create some type of insurance program. And I think that's going to continue if we don't see a big change. We need to expand our primary care services, a lot more federally qualified plans, electronic medical records. There's multiple things that we can do that can help us to improve access to care and to provide more services. Now, I'm almost out of time, so I will take, if you have, is there a couple of questions or comments, and then we can entertain perhaps some just prior to the break. I know I tried to cover a lot of material in a short 45 minutes. Yes, go ahead.
What would be the best advice we can give someone? I'm a recently graduated YouTube student, and I've encountered many people, family members or friends, who say, I'm a citizen, I don't have insurance. Where do I go to rescue them or just help them find out more about that? So where would you help us go first?
Well, all the federally qualified plans here in El Paso, for example, LaFay, Project Vita, San Vicente, the Baptist Clinic, I don't think they're federally qualified, but they will all take individuals who have, they don't ask questions about immigration status. So they can all go in to seek care, and it is on a needs basis. So depending on what your income is, you pay a small copay. So they can go in for primary care. It's much more complicated, however, to get a diagnostic workup for a significant medical problem like an MRI or you need an upper GI or whatever it might be. Those become very challenging. But at least for basic primary care, they can go in and get those services. One more question and then we'll move on. I'll be available. Yes, Joe.
Do you have a lot of federally funded clinics here?
Unfortunately, we have just...
And my question
Yeah.
really, if you do,
Yeah.
is do they have programs to try to show people how to get health insurance? Because one of the things that our federally funded clinics do in the Lower Rio Grande Valley is they discovered that a lot of people actually could get health insurance. One, the point you made, which is a lot of people aren't aware of the system here, and they don't know they can get health insurance. And so they have an actual program in each of the clinics to look for people in their clientele, among their clientele, and then try to figure out how to help them get health insurance.
Did everybody hear the comment? Basically, what we're looking at is what do we do on patient eligibility specialists? And so, yes, most of the clinics do have patient eligibility specialists that they work to be sure that they're eligible, try to find everything they're eligible for. I know Thomason's very aggressive about that to try to capture every program they can. But I think there's a lot more room to grow in that. In fact, we've had put in a proposal to actually create positions for the eligibility specialists, and then the second piece was the patient navigator. Once they get into the system, how do you get through the system and make sure you get the proper kind of follow-up care? But I agree with you, there's a lot more case finding and resources we can do in that area to take advantage, like I mentioned, CHIP, for example, take advantage of that issue. Well, thank you very much for your time.